السلام عليكم ورحمة الله وبركاته. نرحب بكم أعزائي الطلبة العام الدراسي الجديد، نتمنى لكم كل التوفيق إن شاء الله. إن شاء الله راح نعطيكم 5 lectures about the trauma of the lower limb. Now we begin with the first lecture, which including the pelvic injury and the acetabular injuries. We go for a short note about the biomechanics of the pelvis regarding the pelvic instability. As we know, if the pelvis can withstand the weight-bearing loads without displacement, it means that is stable pelvis. However, this is a theoretical definition, and this situation can exist only if the bony and key ligament structure are intact. What about the clinical assessment of the patient with pelvic injury? As we know, the fracture pelvis should be suspected in every patient with serious abdominal or lower limb injuries. The hallmark of injury is the pain, and there may be swelling or bruising of the lower abdomen, the thighs, the perineum, and scrotum or vulva. All of these areas should be rapidly assessed and looking for the evidence of extravasation of the urine, which means the pelvic ring injury. However, all should be done after whole assessment of the whole patient by ABCD or Atlas protocol. The pelvic ring can be gently compressed from side to side to show about the pelvic ring injury, from side to side and back to front. Tenderness over the sacroiliac region is particularly important and may signify disruption of the posterior ring. Another important thing is be caution about the Foley's catheter. Around 30% of cases of pelvic injuries associated with urethral injury. The hallmark is blood at the external urethral meatus. So if we insert a Foley catheter, this will change the partial urethral injury into complete and complicate the problem. So there is caution in Foley's catheter at the emergency setting. Second things, we go for imaging to the pelvis. In general, we can classify it into standard and additional views or Judate views. Standard including AB and lateral radiograph. The Judate views including inlet and outlet for the pelvic injuries and iliac and obturator obliques for the acetabular injuries. As shown in this picture, this is the standard AB radiograph and section C and D, which showing the inlet view as the beam at the legs of the patient directed forward to see the inlet, and as in this picture, which is the outlet view, the beam at the head of the patient and projected caudally. This is part of special views for the acetabular injuries as shown. This is the oblique views, whether the obturator and iliac oblique, and show different part of the pathologies at the acetabular fracture. So the injuries of the pelvis can be classified in general in 4 types. The isolated fracture with intact ring, type 2 fracture with the broken ring, whether stable or unstable, type 3 fracture of the acetabular, type 4 sacrococcygeal fracture. So isolated fracture can be divided into avulsion fractures, direct fractures, and stress fracture. Avulsion fracture, it means a piece of bone is pulled off by violent muscle contraction. These need nothing rather than the rest and analgesia and simple reassurance. Other is direct fracture, which result from direct blow to the pelvis and usually occur after fall from height on a hard object and may fracture the ischium or iliac blade. And also this is part of stable injuries or stable pelvic fracture and treated by reassurance, bed rest and analgesia. Other is stress fracture, which is fracture in the pubic rami, which is fairly common and often quite painless, especially in severely osteoporotic or osteomyelitic patients. Type 2 is the fracture of the pelvic ring, which can be classified according to the mechanism of injury, whether anterior posterior compression or vertical shear or combined injuries. Anterior posterior compression, also called open book fracture. The pubic rami are fractured and externally rotated and so-called open book injuries. Vertical shear, fracturing of the pubic rami and disrupting the sacroiliac region on the same side. And this is an unstable fracture. Combination of these injuries in severely pelvic injuries may be combination of the above, whether anterior posterior compression and or vertical shear or subtypes. As shown in this picture, the picture A, which is mean anterior to posterior compression, disruption of the anterior element and sprain of the posterior element, and this is so-called open book injuries. Lateral compression, the force is directed from the right side, from here to left side, showing injury to the ring at the iliac blade, injury to the superior inferior pubic rami, and lateral part is called open book, so sprain of the sacrotuberous ligament. Type 3, the vertical shear, which is called injury to hemipelvis. So sprain of the anterior element and sacrotuberous, sacrospinous and posterior sacroiliac, so vertically unstable. What we mean by stable and unstable fracture? Stable injury is defined as that one will theoretically allow full weight bearing without the risk of pelvic deformity, as I mentioned previously. Because the mechanism which cause these injuries are fairly consistent, so typical pattern and displacement are defined, which make it possible to deduce the mechanism of injury and the type of ligament damage and the degree of pelvic instability, as I mentioned with the explanation for this photo. In general, the pelvic fracture can be classified according to the Young and Berg's classification into anterior posterior and subclassified into type 1, type 2 and type 3, lateral compression type 2, and type 3 is vertical shear injuries. It's very important classification and also guide the management. Anterior posterior compression and also called open book injuries, which mean diastasis of the pubic symphysis or fracture of the pubic rami, and the posterior sacroiliac elements may be strained or sprained. Anterior posterior compression type 1, it means only slightly diastasis of the symphysis less than 2 cm, although sometimes invisible on X-ray. There will almost certainly be some strain of the anterior sacroiliac ligament. And this type, the pelvic ring is stable. Anterior posterior ABC type 2 injuries, it means diastasis more marked on the anterior sacroiliac ligaments, and also sacrotuberous, sacrospinous ligament are torn. Also, CT may show slight separation of the sacroiliac joint on one side. But all these mentioned with still the pelvic ring is stable. ABC type 3 The anterior and posterior sacroiliac ligament is torn, and CT showing the shift or separation of sacroiliac joint. And this affects one hemipelvis, and this means the ring is unstable. Type 2 in general, type 2 Young and Burgess is lateral compression or LC injuries. The hallmark of this injury is transverse fracture of the pubic rami, often best seen on illet view, as I mentioned is special view. There may also compression of the compression fracture of the sacrum. It can be subclassified into three types. Type 1, the ring is stable. Type 2 is more severe. In addition to anterior fracture, there may be fracture of the iliac wing on the side of impact. However, the ring is still stable. LC type 3 is worse, as the victim is run over or rollover injury called lateral compression force on one iliac ring, resulting in opening of the anterior posterior force on the opposite side, causing injury pattern typically for that mechanism. That means one side is compression and the other side is open book. Type 3 in general is vertical shear or VS injuries. The hemipelvis is displaced in a cranial direction and often posteriorly, as well producing typical asymmetrical appearance of the pelvis. The hemipelvis is totally disconnected and the pelvic ring is stable, and also sometimes this is called spinal dissociation. If occur on each side of the pelvis, it is called spinal dissociation. It means the spine is disconnected from the lower limb. Okay, so as I mentioned, the pelvic fracture is very important and it's a part of general or mass casualty or mass trauma to the patient and should be assessed by Atlas protocol and associated with high mortality and morbidity, so should manage perfectly. The early management, if we deal with the patient with pelvic fracture, so 6 questions must be asked and the answer acted upon as they emerge. The first question, is the clear airway? Are the lungs adequately ventilated? Is the patient losing blood? Is there is an intra-abdominal injury? Is there is a bladder or urethral injury? And is the pelvic fracture stable or unstable? It's a very important question and should be answered in treating and dealing any patient with pelvic fracture. Treatment of the fracture for patient with very severe injuries. After good resuscitation, stabilization, go for theater. For early external fixation is one of the most effective ways of reducing hemorrhage and counteracting the shock, which is the mainly killer for the patient with pelvic fracture. And this external fixation has its indication for pelvic injuries. Isolated fracture and minimally displaced fracture, these need only bed rest and possibly combined with lower limb traction to hold the patient in bed for 4 to 6 weeks, and the patient is usually comfortable and may then be allowed up using crutches with partial weight bearing. In addition to this mentioned, we should take in consideration the DVT prophylaxis, because any patient with pelvic injury has high risk for DVT. Other type is open book injuries. I mean the gap is less than 2 cm, there is no displaced or posterior disruption, which is treated satisfactorily by bed rest, posterior sling or pelvic binder, which help to close the book. Open book injuries treated by closing the book. The most efficient way is by external fixation, with bends in both iliac blades, connected anteriorly by a bar. As with this happy young patient presented with open book injuries, which is treated by external fixation with pins inserting the iliac blade and connecting bars in the triangular fashion. This is the X-ray showing external fixation, and another modality is the anterior symphysial plate and screws. Complication of fracture pelvis in general is the DVT, which is the killer. Deep vein thrombosis or pulmonary embolism, because the patient recombinant in bed, and also it is a part of major trauma, may be complicated by DVT. Other is sciatic nerve injury. Nerve is injured usually in neuropraxia, and one can afford to wait several weeks for sign of recovery. Around 70 to 80% of cases in neuropraxia. Urogenital problem, either from the injury itself or iatrogenic, from insertion of the Foley's catheter, which result in stricture, incontinence, or even impotence. Persistent sacroiliac pain due to partial or complete sacroiliac joint disruption or arthrosis of the sacroiliac joint, and sometimes arthrodesis is needed. Okay. Another important thing is the fracture astabulum. The Astabular fracture can occur when the head of the femur is driven into the pelvis, whatever the force, or the anterior posterior directed or lateral to medial directed. The Loternil classify the astabular injuries, which is difficult classification, to elementary and associated type. But in general, this picture will solve the problem and classify the astabulum into column, the anterior, posterior column, anterior and posterior wall. This is the anterior part of the astabulum, and this is the posterior part of the astabulum. This is anterior column fracture. This is posterior column fracture. This is the transverse fracture. This is the T or Y, both column fracture. And this is the associated type fracture. As we mentioned, for the pelvic fracture, astabular injury is part of the pelvis, it's part of the major trauma, and should be assessed the patient as a whole. Treatment, the emergency treatment, the first priority is to counteract the shock, which is killer to the patient in early hours, and reduce the dislocation of occur to reduce the risk of avascular necrosis. After reduction of dislocation, so skeletal traction pin is then applied to the distal femur rather than the proximal tibia to allow full movement of the knee, which can accommodate 10% of the body weight, or around 10 kg, which will suffice to produce a stable hip. And during the next 3 to 4 days, the patient general condition is brought under control. Occasionally, additional lateral traction may be needed, especially in cases of central dislocation. The definitive treatment should be delayed until the patient is okay, and shouldn't pass the 2 to 3 weeks, because the later on difficult to manage astabular injury, especially displaced type. Complication of astabular injury, which including DVT, especially proximal venous system, iliofemoral veins, sciatic nerve injury, especially if associated with posterior hip dislocation or posterior lip injury, heterotopic bone formation due to bleeding, swelling, and extensive muscle injury, avascular necrosis, especially in neglected posterior hip fracture dislocation, loss of joint movement, stiffness because of intra-articular injury, and secondary osteoarthritis. Injuries to the sacrum and coccyx, which is that subject, it's usually uncommon injury and result from direct trauma, blow from behind, or fall into tail, and may result in sacrococcygeal injury, or sometimes sprain of the associated ligaments. Women seems to be affected more than men. X-ray showing either transverse fracture of the sacrum or fracture of the coccyx, or sometimes normal appearance, which means sprain of the sacrococcygeal joint. Treatment usually conservative, but if the fracture is displaced, the lower fragment should be pushed by digital rectal examination or using the rubber ring cushion when sitting, and support and analgesia. In resistant cases, we can excise the distal fragment. And that's all, and thank you.